Okay. Hello, everybody. We are going to start in a few minutes, so we are waiting. We check the last things, and then we will start my presentation that will be about ultrasonics and the use of magnification in endodontics. So we wait some minutes, and then we will start with the presentation. Things, and then we will start my. Hello, Jeffrey. Hello, Luca. How are you? I see some friends here. Very happy. I see some friends, some Italian friends too. Okay, checking the last things. We will start at 3 o'clock, so a few minutes. Hi, everybody. Hi, Alberto. How are you? Hi, Erlind. We start in a few minutes. Hello. Hello, doctor. Okay. Okay, thank you, Alberto. I'm happy that you like my glasses. 2 minutes, and I will start my presentation about the use of magnification, the use of microscope, and the use of ultrasonics in endodontics. I will show you some cases, some of my clinical cases, in order to discuss with you the possibilities that we have today matching the work of microscope and ultrasonics. I think that if we use these two instruments together, we can get very, very good results in our practice. Hello? At 3 o'clock we will start in 1 minute. Hi, everyone. Okay. Okay, we will start the presentation, the lecture. I am very happy today to speak for Zumax. I'm very, very happy, and I want to thank really Zumax for the invitation to participate in their webinars, because they give us the opportunity to share many useful informations to put into practice as soon as the work situation will be back to normality. We hope every one of us hope that this situation of coronavirus will be back to the normality very fast. Okay, we hope that we will go back to work in the normal way in few weeks, in few days here in Italy, at least. Okay, and my name is Francesco Piras. I am endodontist. I am endodontist from Florence. I have my private practice in Florence. Florence is a beautiful town with a lot of art, piece of art. You see here the Duomo, you see here the David, and it is here in the center of Tuscany in Italy. And I have my private practice, my own practice there in Florence, and this is one other part of my work. I work also, I collaborate also with the university. This is my master, Professor Elio Berutti. Here I am in the endodontic department of Turin Dental School. And here I am doing with my friend Claudio Farnararo, I'm giving courses of microendodontics and endodontics. And I have to say that we are very happy because we meet many friends and we can share our passion, our love that we have for endodontics. And this is a very beautiful part of my work. Maybe the part that I love the most of this work. Okay, in my work, one of the most important instruments that I introduced in my clinic, my office, in many years ago, so I would say that is 12 years ago, now is the microscope. I think that the microscope have been the instrument that gave me the possibility to grow as a professional a lot. So for me, it is a very important instrument because I use it every day. I use it for the diagnosis. And I think that one of the most important things is that it gives me the possibility to communicate with the patient. I can show him the problem that affects his tooth, for example. I can explain to him which is his clinical problem, and we can find together the way to solve that pathology that the patient has, so he can understand exactly what I'm doing, how I am managing his problem. And for sure, it is very important in these steps of endodontic procedure, the access cavity. For me, when I prepare the access cavity, I always start with the burrs, my access cavity, but then when I finish, I put the microscope and I finish it with magnification and ultrasonics, because we are very precise, we are very accurate. Then it is very useful for locating the canal orifices. It is fundamental. I couldn't work without it. And then it's very important also for non-surgical retreatments and apical surgery. I will show you now some cases. Now I will discuss with you some literature, but then I will show you some cases because I want to show you what we are able to do with the microscope, matching it with the ultrasonic tips. Okay. In endodontics, we see here some application. In endodontics, it is necessary for the localization of the canal. Microscope, I think that is fundamental because it is not unusual to miss a canal while we are performing an endodontic treatment, especially if we are treating many molars, a lot of molars, like I do because I am an endodontist. I have many referred patients, and normally I treat molars and I do retreatments. And we know that in molar teeth, we have a number of canals that is greater than the number of the roots. And in addition, we have also to say that we have to pay attention to the initial step of the treatment, that is the access cavity, because we know that if we prepare an inadequate access cavity opening, then will be more difficult to identify additional canals. And we know that the inability of the operator to treat all the canals is one of the causes that can lead to an endodontic failure, because the bacteria remaining inside the canals can lead to the persistence of symptoms. Here you see this study that have been conducted on more than 5,000 molars and showed that the lack of localization of the MB2 canal had led to a significant reduction in the long-term prognosis of those teeth. And you see here, for example, that the MB2 canal in first molars have been untreated in 66% of cases that are failed, and here in the 40% in second molars. What we have to do is easy, we know it. What we have to do is, if you want to look for this canal, is to work with magnification. Here I'm working in order to find the MB2 canal. We know that we have to remove that layer of dentin that normal recovers the access of the MB2 canal, and normal there is some clear dentin here in this point that we have to remove in order to have a straight line access. Here we have to remove this layer of dentin that is clear, and we have to remove it in order to have a straight line access inside the MB2 canal, and then we are able to prepare it. But if we want to find this canal, the first thing that we have to do is to see where this canal is. And normally, if we use, for example, loops, or we work without loops, we work with naked eye, many times it is impossible to localize this area and to find this canal. And in this other prospective study that has been conducted by Hohen and Pink, we see that the incidence of missed canals here is the 42% of all more than 1,000 endodontically failing teeth. It means, what does it mean? It means that it is very important to see what we do, because in this way we can be sure that we have treated all the anatomies of the teeth that we are treating. And here you see another case of retreatment. You see another case of retreatment, and you see here that layer of dentin, okay, that is here, that covers the entrance of the MB2 canal. That is the dentin that we have to remove if we want to be able to find. Now I'm checking with the probe where is the MB2 canal. That layer of dentin, we have to remove it. We have to see it and remove it with the ultrasonics. This is very important. Obviously, the success rates in endodontics, in the retreatments, increases when the operator has the knowledge of the anatomy. This is very important. While we are performing endodontic treatments, we have to know the anatomy of the teeth, because anatomy is variable. Anatomy is difficult many times. So we have to know anatomy. This is the most important thing. If we want to find the canal, first of all, we have to know where the canal is. Then we have to see it. And for sure, the microscope is very important. The equipment in endodontics, especially in retreatments and surgery, I think that is very important. In this work, you see that they showed on 200 molars, you see naked eye is possible to locate 641 canals. With the microscope, 691 canals. It means that we have a 7.8% in increasing in locating canals. That means that we have also an increasing of the success of our therapies, because I already said that if we are not able to find all the canals, we risk to have a failure. So it's very important to see what we are doing. And in many situations, I would say, I'm starting showing you some cases that I hope that are interesting. But I would say that it is not possible in many cases to locate canals if we have not the light. This is very important. We need a bright light, a clear light. We need to see what we are doing, I repeat. And here you see this case in which the colleague tried to find the canals. He sent me this case, and you see that he worked on the floor with the burrs. You see here the shape of a round burr here in the bifurcation area, okay? But if you see here, you see this area that is darker. This is the floor. This part of prepared tooth is not the floor, okay, because it is whiter. So we have to find the canals in this area that is darker, and we have to start from here. This is the mesolingual canal, and we move on this black line here up to this point that is the mesobuccal canal. And you see here in the video, you see, maybe you see better, okay? This is a micro opener that is a K file, 4% paper mounted on a handle, and it helps me using the microscope to see the floor. And you see that here I'm checking the canals. So this is not a difficult case if you have all the instrument that you need. Okay. And this is the case that I finished. You see here very well the shape of the round burr on the floor. And you see the mesolingual and the mesobuccal canal prepared. And here the black line that maybe we have some technical problem, connection problem. Maybe we have some technical problem, connection problem. Okay, let me see, sorry. Yes, I'm trying to have the connection. Let me see, okay, maybe I am online. Okay, maybe sorry. We have some technical problem, connection problem. Okay, you see, sorry. Okay, perfect, sorry. Okay, I go ahead. I'm trying to and let me see. Okay, you see here on the floor the round burr of the colleague that tried to find the canals, and you see here the shape. So he risked to perforate the floor. So every time that you have a difficult case in access opening, remember to use magnification. This is very important. And ultrasonics working on the floor. Here, another case, sometimes microscope alone is not sufficient. This was a case of dense indente, so a very difficult anatomy to treat, to manage, in which I had some difficulties to understand the anatomy of the tooth and to find one of that 3 orifices that you see here. You see that here on the tooth I have 3 orifices, 1, 2, 3 orifices for the entrance inside the main canal. So CBCT here was really useful and important for the solution of the case because it helped me to find all the orifices to enter inside the tooth and starting my therapy. That is very easy in this case. This is a necrotic case. Normally I treat necrotic case as they are exactly in the same way that I treat vital cases, because I make my shaping, cleaning, and obturation in 1 session. I normally don't treat teeth in 2 sessions. When I can obturate and I can clean, I'm sure that I have made good work with my cleaning. That is a very important step in endodontics. I always obturate my cases. Here you see with the microscope how it is easy to see this difficult anatomy. Okay, and these are the 3 orifices that I found it, and I could treat. This is my final obturation, and this is a follow-up after 18 months with the healing. And the patient is very happy because for him was really a big problem, this lateral incisor with this problem, okay? Okay. Okay, which are the applications of ultrasonics in endodontics? Well, more or less, I said before that we can match the use of ultrasonics with the microscope, and we will have very important and very good results. Here, for example, you see that the ultrasonics are very useful in access refinement and finding calcified canals, because we can make a very precise work to remove the restorative material, in the removal of intracanal obstructions, like, for example, posts, broken instruments, and root canal filling materials. Also, they are useful in some situations for activation of irrigant solutions, and for sure, they are very useful in surgical endodontics. I couldn't perform today a surgical endodontic treatment without my microscope and without the ultrasonics. I will show you some cases in this presentation. Why we had advantages using the ultrasonics? Well, the first thing is that because of the shape of these instruments, because the angle facilitates the access to any teeth, increasing the visibility and safety. Then we can use tips that have diamond coated tips, increasing the cutting efficiency and the precision. We have to say also that with the ultrasonic, there are many manufacturers, and also there are a big variety of length and width. And so we can find the tip that we need for that specific use. And for sure, I have to say that I love to perform surgical endodontics, and I love to perform it using multi-angle tips to facilitate the access to any clinical situation. Okay, we know that I would like to show you this article because we know that the mean measurements for the maxillary and the mandibular molars are around 8 millimeters from the cusp to the floor. And it means that if we are making the access cavity opening and we use a burr in the initial part of the treatment that is 6 millimeters long, okay, if we are working for sure in intact tooth, we are always more or less 2 millimeters far from the floor. Why I show you this article? I show you this article because normally when I perform an access cavity, when I start my treatment, I start the treatment not with the not with the ultrasonics, but I start the access with the burrs. I think that the first instrument that we have to use while we are preparing the access cavity is the burr. And normally I start, if I'm working on molars, upper molars, lower molars, or upper premolars, I start with a burr that is 6 millimeter long, because I know that if I use a burr that is 6 millimeter, I will never be in contact with the floor. I will be more or less always 2 millimeters far from the floor. And I would say I said before that it's very important to match the use of the microscope with the ultrasonics. This is very important in my practice. And you see that with the ultrasonics, we are able to clean inside, we activate the water port of the ultrasonic tip, and we are able to see very well the floor. And I see here, for example, in this part that I left some piece of roof, okay? We have to remove always all the roof in order to have a perfect vision of the floor of the tooth that we are treating. This is very important, because in this way we are able to remove from the side of the pulp chamber all the residues of the debris that we make using the ultrasonic tip. This is very important. And if we see like this, the risk of perforation the risk of perforation is more or less zero. Okay, if we use, especially if we use a tip that is smooth and in his final part. Okay, this is a very important thing. And you see here that the visibility is perfect. We see the palatal canal that is here on this upper molar, the distal and the mesial, and here is the MB2 canal. So now what I am doing is moving my tip. Here I am magnificating, and you see that we are removing also a little calcification from the inside of the pulp chamber. And we can finish perfectly removing all the pulp tissue from the inside. This is a very precise work. And I would say that while I am doing this work, I feel safe. I don't have to think that if I am, for example, perforating the floor or there is any problem. Okay, in this way, I am sure that I am not damaging at all the tooth. And I am doing a good job. You see here a little pulp stone that is here. We have to remove it. We don't start to insert the instrument, the endodontic files inside the canals if the access cavity is not prepared in the right way. This is a very important step. I normally take time for this step. I think that this is the step that put me in the best situation in order to have a good endodontic treatment, because I know that if I open in the right way the access, I open it with the magnification, the ultrasonics, I know that in the following steps that are the shaping, the cleaning, and the obturation of the canals, I will be facilitate in that steps. Here I'm looking for the MB2 canal. You see with the probe I'm checking to see if there is any MB2 canal here, and then we are able to start with the endo treatment. Okay. Another case of access cavity. This is not a very easy access cavity. Because why? Because it's a very small pulp chamber here. We have a calcified pulp chamber. In these cases, I'm using this multi-blaze tip, ultrasonic tip, with this smooth surface in the first step. What I do in these cases, you see that I'm doing a little hole, very, very little hole here in this point, because I want to enter very gently inside the pulp chamber, and then I finish my preparation with this tip, the multi-blade tip, and I'm moving on the floor, being sure that I am not make a perforation, because I can see perfectly the floor. So I can move on this floor, and I look for the differences in color. You see here, we see very well the floor. Now we can start working, for example, with another tip that is a thinner tip, and I can finish in the right way the access. And this is a very conservative access. This is an access in which I will not have problem in removing structure. We are treating a tooth that have lost a lot of structure. So I don't want to remove a lot of structure and has a tooth that then can't support the stress of bite stress. This is the final obturation of the canals, and you see that we are very, very conservative. We remove only the tissue that we have to remove, and you see that we are facilitated in entering inside the canal and to maintain also the anatomy of the canals. This is very important. When we are performing an access cavity, we have to be sure that that can't influence the quality and the geometry of the shaping of the canals. This is another very important aspect. Another difficult case in which, in my opinion, the use of magnification, microscope, and ultrasonic is mandatory. You see here, for example, that we have a pulp chamber that is full of calcifications. So it is impossible if I don't see to open this tooth. So what we do here, we start removing all the amalgam When we are performing the access cavity, when we see the amalgam, we remove all the amalgam because this amalgam then, if we modificate the access, could fall inside the canal. So I like to remove all the amalgam, and then I will start working with the ultrasonics on the floor. What we see here, we see that there is a pulp stone that we have to remove because it could fall inside the palatal canal and obturate that canal. Then can be very difficult to find the full working length with the files if that calcification fall inside the palatal canal. So what we want to do here is to remove all the calcification from the inside. We use the ultrasonic. Now I'm using a thin ultrasonic tip, and I activate water because with water, I want to remove all the debris from the inside of the pulp chamber. I move inside with the ultrasonic tip. I clean very well the inside of the pulp chamber, and you see what? This is the first upper molar. You see that here it is the MB1, and on this line I have to look for the MB2. This is palatal, this is distal. So I have to move in this direction with the ultrasonic tip and start working initially at this point, okay? I normally put my ultrasonic tip, that is a special ultrasonic tip here, that is tapered, I would say, and I move a little bit initially. In this way, I am able to remove this layer of dentin, and I am facilitated in entering. I have a straight line access to the MB2 canal. This is my final obturation. That was a necrotic tooth made in one session. I don't treat necrotic teeth in 2 sessions normally, if there are not other problems, but normally I treat it in only 1 session. This is 6 months follow-up. And you see the access cavity that is very, very conservative. Normally I make parallel walls. I don't try to have divergent walls. I'm not interested. I have a good vision. I use night eye instruments that are flexible, so I don't need to have divergent walls. Normally parallel walls for me is sufficient in order to reach a good access cavity that allows me to treat it and shape it and clean and obturate in the right way without any problem, okay? We go ahead. Another important thing, I think that in retreatments, while we are performing retreatments, we have to use these instruments. They are mandatory. We can't perform a retreatment, a difficult retreatment like this, for example, without magnification and without ultrasonics. I couldn't do it. For me, it would be impossible. I know that I would do some mistake if I don't use the right tools, okay? So here we use this tip that is a sharp tip in the tip, and I move on the composite, and you see that I am able to break the composite with this tip. So I start removing very gently, activating. Normally I use the ultrasonics with high intensity because I want to literally destroy the material from the floor. I want to remove it from the floor, and now you see that I'm starting seeing the floor of the tooth. So it's very easy now because I only have to move distally, and we start to see the gutta percha here, mesially, here mesiolingual, mesiobuccal canal. So now it's very easy to remove all the material during this retreatment. Another case, okay, what we do, what we see here in this preoperative orthogonal radiograph. Here I would expect to see the buccal and the palatal canals that are superimposed in the center of the root, but in this case you can see clearly an asymmetry between the buccal canal and the palatal canal. This means that for sure there was a missed canal in the distal. Okay, so when I see a clinical situation like this, I normally think that if the palatal canal and the buccal canal are not superimposed, it means that probably I will find a distal canal that is a missed canal. So what we do here, well, I perform my access cavity that normally in premolars, upper premolar is an access cavity that is centered. Okay, in the center, I do it with the burr, and when I start seeing this guttapercha, I stop working with the burr, and then I start working with the ultrasonic tips. And I move, in this case, distally. It is easy, I have to move distally. So with the ultrasonics, you see that I am moving distally in order to remove this dentin that blocks the entrance inside the distal canal of this premolar. So now I'm gently and in a very precise way working with the ultrasonic, removing this dentin in the distal part and working on the floor. Okay, searching the missed canal and finishing the access cavity walls. Okay, now you see here the floor that is clean. You see here the irrigants inside that are working and they are cleaning. I normally take time, a lot of time for the cleaning, because we know that one of the most important steps of the endodontic treatment is the cleaning. The cleaning is a fundamental pillar of the treatment, and we need time for the cleaning. We can also activate the irrigants. We can also sometimes during the treatments use the ultrasonics, some special ultrasonic tip, and this is very important. So I take time for the cleaning. Sodium hypochlorite and EDTA 10% are the irrigants that I use. I only use these two irrigants in my practice. And here you see the working length, radiograph, and my final obturation. Okay. Okay, and another new microscope and ultrasonics is in the removal of fiber posts. In fiber posts, we have to remember that the first treatment, the posts have been inserted in the straight part of the canal, so it's not so difficult to remove it if you can see it. Okay, a carbon fiber post, it's easier because it is black, but also the white fiber post, sometimes we can see it without any problem. We can remove it without any problem. We work in this way with the ultrasonic. We take a thin ultrasonic tip like this, for example, with the active tip. The final part have to be active, and we start moving apically. Okay, the fiber post is inserted inside the straight line part of the canal, so it is not possible to perforate the root. We have to follow, we have to see very well, and we have to follow the fiber post in order to destroy, literally destroy the fibers and to remove. But then when we are working with the ultrasonics, we will see that we have a dark material inside the canals. When we see that the material is starting getting dark, we activate the water port, we activate the water, we clean inside, and then we will start to recognize better the dentin walls and the fiber post. Okay, what we want to do is go deeper here. Here we see that the posts have not been removed completely from the inside of the canal. So what we have to do here is going deeper. Okay, we have to see, we want to see the guttapercha that is under the post. So I want to see yellow. Okay, now we are happy. You see here that we are able to see the guttapercha that is here perfectly. So we want now we have only to start a normal retreatment with the endodontic instruments, with the solvent, etc., etc. So now the case is a normal retreatment. It's very easy. Okay, here another case of application of the ultrasonic. They are very useful while we want to manage cases in which we have broken instruments. Here in the mesial root, you see, for example, that there is a broken instrument. Okay, my strategy here is to remove this instrument because it is located in the coronal part of the canal, in the coronal portion. In other situation, I could decide, for example, to bypass the instrument. But in this case, the instrument is in the coronal part of the canal, and it is in the straight portion of the canal. So with the magnifications and the ultrasonics, we start the removal of the instrument, okay? What we have to do? In the first step, I create with a tapered tip, ultrasonic tip like this, space, enough space coronally in order to use in a second step a thin ultrasonic tip. Okay, so now I try with this tip to create this space up to the instrument that is broken. I create a tapered part of the canal, an intentional ledge up to the head of the broken instrument, and then I will start with a thinner tip, different thin, working around the head of the broken instrument in order to remove it, okay? And in this second step, I start with this thin ultrasonic tip to vibrate the instrument at medium low power, and you have to work 360 degrees around the instrument head. You have also to create enough space, usually it is 2-3 millimeters, in order to be efficient in vibrating the tip around it. So you see that I'm going counterclockwise. Remember that I am working in direct vision. Sometimes it's not easy to understand it, but we are working in direct vision. So we work counterclockwise, and if you follow the right procedure, you will see the instrument popping out from the inside of the canal. What we have to do in these cases is not to be very aggressive inside the canal because there is the risk to perforate, there is the risk to break the broken instrument again. So sometimes can be very, very difficult to remove it from the inside. And you see that now is here. While you are doing this kind of work, remember to put a cotton pellet inside the other canals that you have, for example, already prepared, in order to be sure that the fragment that you have already removed can't fall inside a canal that is already being prepared. This is another important thing that we have to remember. Okay, and this is my final obturation. So this is not a difficult case because the fragment was coronal, so it was not so difficult to manage and to remove it. Okay, another case of broken instruments. This is a very difficult retreatment because you see that here we have amalgam obturation, we have a broken instrument here, we have gutta percha here, and maybe we can suppose that, but we also see in the radiograph, we can have also a distal canal that is a missed canal. So what we do here? Okay, we start working with ultrasonics and magnification again. This is very important. We have to clean inside again because we have to see very well what we are doing again. And now you see that the floor has a darker color than the surrounding walls. And this drives me to the localization of the canal orifices. Okay, remembering that initially I have to find a missed canal. Okay, now we are approaching the broken instrument. That is a broken instrument. With the probe, I'm touching it, try to understand if this instrument is possible to remove it or there is some difficulties. Okay, I start vibrating the instrument with the ultrasonic tip, rounding and trying to make it pop out from the inside of the canal. Ultrasonics, when the instrument is coronal, are very efficient, so it is not difficult to remove a broken file like that. That's a broken file here, and these are this is the radiograph that I took in order to be sure that I removed all the fragments from the inside, but also the radiograph that show me this in very difficult anatomy of this lower premolar. these are the files inserted inside. My final obturation made with the shielded technique, and this is a follow-up after 2 years with the complete healing of the lesion. Another case in which I removed an instrument. This is a case in which we had a very long fragment inside the canal. Why we had a long fragment like this inside the canal? Because the access is too small. So the colleague started working here from a very, very small access cavity. And when the access is too small, we risk that the instrument breaks in the part where it is bigger, because it is more tapered. So it is possible that it makes a curvature can break for cyclic fatigue. So what we do here is correct the access. So I open a little bit more the access. And the other thing that I do, I start to work with a tip like this. So a thin tip, but sharp tip around the head of the instrument. Now I want to use a different system for the removal of this instrument. I will use a loop system. So what I'm doing here, I am putting the loop around the head of the instrument. My assistant now is rounding. You see her hand here that is moving. Is rounding the final part of this instrument in order to be sure that we can take strongly the test, the head of this file, this broken file. Now we are sure that the loop took the file, and now I can try to remove it. Okay, so I will try to take it away from the inside the canal. Okay, the fragment is here. We are very happy. Very long fragment of file, you see, and we are very happy. This is a very fast work. I did it in 1 hour, all the treatment, so it was not very difficult. The important thing, I repeat, especially in retreatments, is the equipment. The equipment is very important. If you have the right tools, the right equipment, magnification, ultrasonics, extractor like this one, everything is very easy. You need maybe some experience, but everything is not difficult. Another case that I want to show you in which ultrasonics and the microscope are really very important and make the difference. Here you see I have another fragment. In this case, I tried to bypass the file. I wanted to bypass the file because it is in the middle third of the canal and in a thin root of this molar. So I tried to bypass the canal. I was lucky in this case. I bypassed the canal and I made all my treatment. I made all my cleaning, and I also obturated the MB2. But after 2 months, the patient had a sinus tract, and the sinus tract couldn't heal. So we decided for endodontic surgery. Endodontic surgery here with the 3 millimeters oval micro mirror. You can see that I already cut the root, and you see that I can find the broken instrument inside the canal. I can prepare MB1 and MB2, and I am able also to remove it. Here the instrument that is going outside while I was using the ultrasonic tips. This is my final obturation and the healing of the patients after 6 months. Again, another case of endodontic surgery. Another case of endodontic surgery on this already treated lateral incisor with this big post inside. Here with the patient, we decided to perform an endodontic surgical treatment. So what we do here with this tip, I am preparing the canal. This is a long tip because I wanted to prepare up to this point more or less. I didn't cut the apex in this situation. I only finished it with a burr, and then I started preparing the canal with the ultrasonic tip. The most important thing in these cases is to follow the long axis of the tooth. Okay, this is very important. I am moving my ultrasonic tip inside the canal, removing the gattapercha. While we are doing this kind of work, we activate and close the water port because Without water, we remove the guttapercha. With the water, we can clean it outside from the inside of the canal. Okay, so I am finishing my preparation with the ultrasonic tip here. You see that I made a very small flap, okay, because with the microscope, we are able to be minimally invasive during the endodontic surgical procedure. We are minimally invasive. The bony crypt here is a bony crypt of 4 millimeters, so it's very small. And you see that with the micromirror, we are able to see inside the canal. Here I put a cotton pellet in order to, in order to have, to stop the bleeding from the inside the bony crypt. This is ferric sulfate, brown color. Okay, in order to have the field that is dry. This is very important while we are performing the obturation. Okay, now I am performing the obturation with the map system. I'm putting inside MTA. I use two materials for the endodontic surgery for the obturation. I use MTA and I use super EVA sealer. Sometimes I also use some bioceramics, but normally I perform my obturations with the MTA white. Okay, you see also that I colored here with the methylene blue in order to be sure that I cutted all the root surface. You see I increased the magnification because I want to be sure that I am doing a good job, that I am not having some bleeding. This is my final obturation, and this is the patient after the suture. This is at the suture removal after 48 hours. You see the aspect of the tissues, and this is after 7 days. Okay, so you see that the minimal invasive procedure, the minimal invasive surgical procedures are very good for the patient, can improve the possibility of a good healing for the patient. Now I will show you this case, this other case of endodontic surgery. This is a retreatment. This is a surgical retreatment. You see that this tooth had here, this amalgam obturation was failed. So we decided with the patient to make a surgical retreatment. And we want to use a modern technique. We want to use the magnification. We want to use the microscope. We want to use the ultrasonics that are very important. So this is how we remove the amalgam. This is how we remove the amalgam. I start working around this amalgam fragment with the ultrasonic tip, creating a space around the amalgam. And I put inside also a cotton pellet in order to take all the little fragments of amalgam that can move from the side of the root while I am preparing with the ultrasonic. I'm not destroying the amalgam. I want to isolate this amalgam fragment, okay? In order to take it and gently remove it from the side of the bony crypt. Okay. So what we are doing here with, I am trying to dislocate the amalgam fragment, the obturation from inside, and then I take it very gently and remove it from the inside of the bony crypt. So now everything is clean and we can start our surgical treatment. Okay, and especially we can start preparing the last millimeters of the root. So now with the burr, multi-blade burr, I am finishing the roots. You see that I am finishing the roots and I am preparing the roots. Normally we cut the roots with a 90 degrees angle on the long axis of the roots. I cut these roots, finish the roots, and now I'm putting the methylene blue. The methylene blue shows me if there is any fracture on the root surface, but also shows me all the ligaments. That's why I can be sure that I have cut, I've removed all the entire surface of the root, I clean inside with some water, and that's okay. I see very well where are the canals, so I can prepare it. And now the ultrasonics. The ultrasonics, it's very important that the ultrasonic tip work following the right angulation, because it is very easy if I work in the wrong way, with the wrong angle, it is very easy to perforate the root. What I don't want is to perforate the root for sure. You see the bleeding is controlled. This bleeding is controlled because I made anesthetics with epinephrine. Here you see MB1, MB2, and here you see the isthmus between MB1 and MB2. So we start preparing the MB1. The MB1, why I start preparing the MB1? Because the MB1 is already prepared, so it is easier than the MB2 canal. It is easier to prepare than the MB2 canal. So I prepare, MB2 canal is a missed canal, have not been prepared in the first treatment. So I prepare the MB1, then I take the inclination of the MB1 and with the same inclination, I treat the MB2. So I put the ultrasonic tip inside the MB1 and then I go inside the MB2 in order to be sure that I am preparing it with the right angulation, with the right angle, because it is very easy to perforate on that side of the mesobuccal root where I have less dentin. I have less dentin on that side, so I have to be very, very precise and I can't wrong my work there. So now we activate the water port and we clean the inside the canal, and we are able now to prepare the isthmus between MB1 and MB2. Normally the isthmus, we prepare it less the two main canals. The canals, we prepare them more or less 3 millimeters, and the isthmus 2 millimeters, not more. Now we take a look inside with the micromirror, and we see that the preparation is okay, the preparation is good, is correct, and now we can start with the obturation. Everything have been dried, okay, inside the canal is dried. Now we can put the obturation material. In this specific case, the obturation material is the super EVA. I obturated the distal canal, and now I am obturating the mesial canals, MB1 and MB2, and the isthmus. You see here with the micromirror, the MB1 here and the MB2 here, and this is the isthmus, okay? You see the control, the perfect control that we have using the microscope. This is incredible, I love it. Now I start obturating the MB1 and MB2. I put inside my obturation material. It is very important that all the surrounding tissues are dry, and I pack the material inside. Okay, with these special instruments, I put inside again super EVA, and I pack the material inside. My assistant in this moment is watching inside her binocular, because I have the covision for my assistant. My assistant can control perfectly what she is doing and can assist me, help me removing all the bleeding that is surrounding the bony crypt. This is very important because everything have to stay dry if we want to have a good sealing of the material. Now I am removing the excessive part of the material, of the super EVA, from the side of the bony crypt. And now we wait some minutes because this material needs more or less 4 or 5 minutes before we start with the finishing. I make the finishing with the burr. I make the finishing with this multi-blade burr, and I remove all the material that was excessively put inside. Okay, now we are able to check the obturation. Okay, now we check the obturation with the micromirror. We are happy. The obturation is good, is correct. So now I think that it's time to suture the patient and to give him all the recommendations that he needs when he goes home. I repeat, these are treatments that are very, very, very minimal invasive treatments. And my patients are very happy of this kind of surgery because they have no problem. I have to say that normally I have no problem with this kind of treatments, are safe treatments. And the post-surgery is good for the patients. They really are happy of this kind of treatments. Okay. Because the micro approach, in my opinion, is the approach that we should perform for every time for our patients, because it's really a minimal invasive approach if we are treating for the first time a tooth, but also while we are doing the retreatments and while we are making the endodontic surgery. So I suggest to all the colleagues to work with magnification for sure. And I repeat what I said at the starting of my lecture. I said that if this is really true, I think that the microscope has been the most important and the best instrument that I ever put in my office all my life, my working life. So I really suggest to every colleague to think about have an instrument like this in their own practice, because can really elevate and increase the precision of our work. And that's it. This is my final obturation and the final radiograph. And I would like to thank you for the kind attention. Here I am with my friend and colleague Claudio. And ciao Claudio. And so thank you very much to everyone. Thank you especially to Zumax that gave me the possibility to be here with you today. And now if you have some question, I will be very happy to answer to your questions. So I will read your questions and I will answer you. Thank you very much again. Okay, I wait for some question. I will read if you wrote something while I was speaking. Hello, Claudio. Hello, Talal. I see many, many friends here. Hello, Vincenzo. I wait for some question. I will read if you wrote something while I was speaking. Hello, Claudio. Hello, Talal. I see many, many friends here. Hello, Vincenzo. If you have any question, I am here and I will be very, very happy to answer. If you have any question, I am here and I will be very, very happy to answer. Okay, I see some question about the ultrasonic tips. The ultrasonic tips that you use, different goals, is it matter very much the tips? Okay, I think that if we want to, every specific work needs a different shape of tip while we are working. You know, so for example, if you are making, you want to remove some material from the inside of the pulp chamber, you need a tip that is very efficient. Also a very resistant tip, I would say, because if you remove, for example, amalgam or composite, you need a tip with specific characteristics. So you have to, on the market, there are many, many brands. Okay, there are many brands of there are many brands of ultrasonic tips, and I would say that you have to choose the right tip for the right work. This is, for me, very, very important. Well, I would say that someone asked me, oh, wait. Okay. In case of retreatment which already bypassed the fractured instrument, or in case of retreatment which already bypassed the fractured instrument. I have not understood, sorry, this question. Okay, the favorite brands that I use for the ultrasonics. The favorite brands, well, I would like not to speak about brands, but there are many, many brands, okay? So you can choose on the market. I show you some, I think that I show you many kind of brands in my presentation. So I suggest you to choose the right, what I would like to suggest is to choose the right shape of the ultrasonic tip while you are performing a special kind of work. This is the suggestion that I will give you, okay? Okay. Okay. Thank you very much to Zumax. And I really thank you. I wait just a second if you have any other question. It was really a pleasure for me to stay with you this afternoon. Okay. Thank you very much. Okay. Saleh Ahmed, I mean how to retrieve the fractured instrument previously bypassed in retreatment cases. I think that you are speaking about this case. Okay. But it is easy because if you see the instrument, if you cut, for example, the root here and you see the instrument, you start vibrating it with an ultrasonic tip, but it's a surgical tip, okay? So you need a specific surgical tip. There are many brands of surgical tips for endodontics, and you start vibrating it and you see that the instrument literally go outside from inside the canal because it is not retained, it's free. So if you touch it with ultrasonic, it go outside. It is very easy to remove it, okay? Okay, yes. We are speaking also about the cleaning. Well, I have to say that normally I don't use ultrasonics for the cleaning. I can use some specific ultrasonic tip for the cleaning in retreatments if there is some material inside the canal that is difficult to remove. So I could, for example, some gattapercha or some sealer that is have been put inside the canal. So I put inside some irrigant, like for example, the sodium hypochlorite, and I can vibrate it in order to be sure that the material that is inside the canal can go outside, can move from the walls of the canal. Okay, so I can vibrate it in order to remove it from the side. This is, normally I don't activate the irrigants with the ultrasonics. I prefer to activate with the subsonic irrigation. For example, the activator for me is a good instrument. I use it, but there are many, many others on the market, like endoctivator. Okay, so I prefer to use subsonic activation for sure. I don't like to use ultrasonics for the activation because sometimes you touch the dentin walls of the canal and you produce a smear layer. So then it's very difficult to remove all this med layer. And we also could damage the inside the canal. We also could alterate the original anatomy of the canal. And we know that when we alterate the original anatomy of the canal, then we can have some problem in managing the canal. So I don't like very much to clean with ultrasonics. I prefer to use something that can gently activate the irrigant from the inside. It was my pleasure, Saleh. If you have any other question. Hello, Issa, how are you? I see many, many friends today. Very happy. It was my pleasure, Jeffrey. Thank you and cause. Okay. Okay, again, thank you. And if you have not any other question, I stop my lecture. Thank you very much to Zumax again. It was really a great pleasure for me to stay here with you. Thank you very much.